Coronary artery disease, another exciting thing to talk about. So I said in the last section that the heart is its own best customer. The heart muscle, the myocardium, needs oxygen and other nutrients to maintain constant pumping in order to supply oxygen to the rest of the body. So the first exit off the aorta is the coronary circulation. So the exterior of the heart has a network of coronary arteries, which arise from two main coronary arteries, the right and the left. So the right serves the right ventricle and the left serves the left ventricle. Each vessel has tons of branches and branches and branches to supply all the areas of the heart with the blood and essential oxygens and nutrients. So what happens when things go wrong? That's what we're going to talk about. So we're going to talk about coronary artery disease, what it is and its pathophysiology, risk factors. We're going to distinguish between stable and unstable angina and what angina is, and the signs and symptoms of myocardial infarction, understanding treatment approaches for coronary artery disease and myocardial infarction, PTA safety considerations, as always, and red flags requiring immediate medical attention. So coronary artery disease is when a plaque builds up on the inner wall of the arteries, causing the lumen, the opening on the inside of the artery, to narrow. So you can think of it sort of as like arterial stenosis almost. So when it affects the coronary arteries, it can affect like all the arteries in your body. But when it affects the coronary artery disease, it's called, or the coronary arteries, it's called coronary artery disease. So if the plaque builds up in a particular area, a thrombus can form, or sometimes an atheroma, which is a type of thrombus. And the thrombus can form, if it forms in any of the coronary arteries, it can interrupt blood supply to the heart, and then problems ensue, right? So coronary artery disease is the number one cause of death in the United States. And many people don't know they have it until they experience a heart attack. That's like their first symptom. And your first symptom of a heart attack can be that you just die. If your left anterior descending coronary artery, it's the one they call the widowmaker, feeds the left ventricle. If that one is clogged, your left ventricle can't work, that could lead to sudden cardiac death. So the photograph is, the top picture is a regular healthy artery, all smooth and fancy. The little openings, that's the branches that are going off the artery. And then the bottom one is the one with atherosclerosis, ick, right? But you could see how rough and icky it is and how that could cause clots to form or cause areas for clots to form. And you don't want reduced blood flow to your myocardium. So the modifiable and non-modifiable risk factors, this list is becoming familiar, right? You should know this. So you can't do anything about your genetics, your age, your gender, your family history, but you can do something about those other things. So we can help patients modify controllable risk factors through education and exercise, our favorites. So angina pectoris is chest pain, basically. And so chest pain is because the myocardium, or chest pain in myocardial infarction and in angina, is because the myocardium is being deprived of oxygen for some reason, usually because of coronary artery disease. But when we talked about strokes or CVAs, a thrombus blocks a vessel in the brain with an ischemic stroke, the most common kind, and the brain is deprived of oxygen, the tissues are deprived of oxygen for a certain amount of time. That's pathophysiology. It's the same thing with a myocardial infarction. The myocardium is deprived of oxygen for a significant amount of time and cells die. With angina pectoris, it is a temporary decrease in oxygen supplied to the myocardium. And it usually manifests as chest pain or pressure, and it usually lasts a few minutes and in general doesn't cause damage to the heart. However, angina is a warning sign of coronary artery disease. And so you can have angina and eventually have a heart attack. So you can think of angina as being a temporary blockage where cells don't necessarily die. And you can think of a myocardial infarction or a heart attack as being where cells actually do die. So stable angina, it's predictable patterns, like you're out shoveling snow and you have chest pain. So exertion or stress, that's the shoveling snow part. After eating, sometimes it's chest pain or pressure lasting minutes. It's a warning sign that you may be lining yourself up for a myocardial infarction later on. It's usually treated by sublingual nitroglycerin, which is a vasodilator. So a lot of times people wear you can get a little necklace that has your nitro in it. When you're having angina, it's stable angina, it's predictable. You can take nitroglycerin, it goes away. Unstable angina occurs at rest, so there's no predictable pattern or exertion that goes with it. Unpredictable timing because you never know. And so it's more dangerous than stable angina. In general, unstable angina is considered a contraindication for exercise. It does require immediate medical attention, so you want to stop treatment and call for help. So if somebody is just sitting in the waiting room and they start having angina, that is a problem. If they're actually exercising, well, it's still a problem, but it's predictable. So common coronary artery disease medications include statins, which always usually end in OR, like Lipitor or Crestor, and they are cholesterol lowering drugs. Antiplatelet drugs, which prevent clots forming. So sometimes it's just low dose baby aspirin or low dose aspirin, 81 milligrams once a day. Plavix prevents platelets from clumping together. Beta blockers, they reduce the heart rate and blood pressure. So they can be used for heart failure. They can also be used for coronary artery disease, and they end in OL. ACE inhibitors end in RIL or PRIL, Zestril, lisinopril, and they lower blood pressure. Calcium blockers, they usually end in INE, and they relax blood vessels. And anticoagulants like Coumadin, and it's also known as warfarin, prevents blood clots. So it's an anticoagulant. You'll see people on those all the time. So whenever you get a chance to look at the medical record, look at the medications, and you can tell from a list, if you know medications, if you can tell from a list of somebody's medications what their pre-existing conditions are. So a myocardial infarction is a heart attack where a coronary artery is blocked to the point where the heart muscle is deprived of oxygen long enough that it dies, leaving damaged heart tissue. So the pathophysiological sequence with myocardial infarction is you have ischemia, lack of blood supply to the area, anoxia or hypoxia, lack of oxygen to tissues, causing necrosis, cell death, and scar tissue formation. Non-contractile replacement tissue replaces that tissue. So the most common cause of myocardial infarction is complete blockage of a coronary artery due to thrombus formation, a vasospasm, or an embolism. An embolism is a traveling thrombus, where the thrombus decides to take its talents on the road. So just like with an ischemic stroke, the thrombus, the embolism is going to travel until it gets to a small enough artery that it can block the whole thing. The effects of myocardial infarction are going to depend on how much tissue damage there is. So the classic presentation that they always used to teach you in CPR is crushing chest pain, pain radiating to the left shoulder and arm, jaw pain, shortness of breath. Women are less likely to experience classic chest pain and more likely to present with anxiety or indigestion-like symptoms. Also, women are more likely to dismiss their symptoms as being something else. So other symptoms besides the classic presentation, and we can just say that's the classic male presentation, are nausea or indigestion, dizziness, diaphoresis, which is sweating, exhaustion, anxiety, and an irregular heartbeat. So if your female patient tells you that they woke up with additional anxiety or indigestion-like symptoms, that's probably a good call to send her off to the emergency room or call 911, because she could be having a heart attack and not even know it. So for myocardial infarction, um, immediate medical attention is critical. That is very, very important to recovering and not dying from a myocardial infarction. So they're going to do an EKG. They're going to look at blood enzyme levels. Time equals heart muscle, because we said time equals brain with the stroke. Stroke and heart attack are the same thing, just different arteries. So time equals heart muscle. The sooner you can get someone in, the better off you are. So when you go to the emergency room or you call 911 for a heart attack, they take blood enzyme levels, they do an EKG, they put you on telemetry, they measure your troponin level, which will, if you are actually having a heart attack, it will increase over time. So they do like blood draws every hour. They look for certain enzymes that can be altered following myocardial infarction in order to help them make that diagnosis for myocardial infarction. For medical management, they might be using anticoagulant medications, pain relievers, antihypertensive and cholesterol-lowering drugs. Surgical interventions include angioplasty with the peripheral catheter insertion, that's the PCI, where they put in a stent, which is like a little cage to keep the artery open. A coronary artery bypass graft, and it's known by most people in the hospital as a CABG, C-A-B-G. It's bypass surgery using vessels from the leg. You might require multiple bypasses, so you'll see in the medical record CABG times 2, CABG times 3. And in layman's terms, that's like a double bypass or a triple bypass. So it's how many arteries need bypasses. And that's so the CABG. And if you're working in the hospital, a lot of times people are post-CABG times 2. They'll tell you that. So following a myocardial infarction, the outcomes vary depending on the amount of tissue damage, and what kind of care the person got. Usually the person ends up going through cardiac rehabilitation, starting in the cardiac care unit in the hospital, and that's where we take care of them. So we are stage 1, phase 1 of cardiac rehab. And we will talk more about that in lab next fall. So what we're going to see is mild fatigue, slight shortness of breath, heart rate increase within normal limits, mild muscle discomfort, and this is when they're in cardiac rehab. We want to monitor them closely and modify activity as needed. We're going to stop if they have chest pain or pressure, severe shortness of breath, dizziness or lightheadedness, excessive fatigue, irregular heart rhythm, nausea, diaphoresis, and cyanosis. We're not going to be able to detect the irregular heart rhythm unless they're on telemetry. So our emergency protocol for any of those red flags, we're going to stop, we're going to check their vital signs, we're going to call for medical assistance, and we're going to document every single thing. So the main things to think about: coronary artery disease is the leading cause of death. Early recognition of coronary artery disease saves lives. And so there are multiple risk factors that often present together. And women may present differently than men when they're actually having a heart attack. So after the heart attack, you want to monitor the person closely during rehabilitation. And when in doubt, err on the side of caution. Patient education is crucial for preventing future events, and your role as a PTA can be life-saving. We'll talk more about this when we talk about cardiac rehab, but people have much better outcome when they start with cardiac rehab, and that's what we want. We want good outcomes.